Hello everyone and welcome to the unit of psychiatric disorders. Well, I don't mean a unit in a hospital, I mean we are gonna discuss some psychiatric disorders in this unit. Let me start with a very common psychiatric disorder, mood disorders. Now, what is mood? Can I look at you and I say, you don't look in a good mood today? Well, we say this, we use this expression, but actually I cannot know what is your mood. Only you who knows what is your mood. I can only see your affect. So the affect is the external display of one's mood. Normally, it's normal to have some fluctuations in mood. That's normal. But mood disorders, we talk of mood disorders when you have 2 blue weeks, that's depression, and causing impairment in the daily life, that's depression. Depression affects women more than men, and mood disorders are very common. The types of mood disorders, major depressive disorder is the most common type, but don't forget that we have bipolar disorders. In bipolar disorders, the patient's mood swings between depressed and happy and elated or manic mood. As I said, what do you need to diagnose major depressive disorder? 2 blue weeks. The symptoms of depression have to last for at least 2 weeks to diagnose major depressive disorder. Cyclothymic disorder and dysthymic disorder is some sort of a depression light. Here, you need to have 2 years of mild depressed symptoms to diagnose this condition. Seasonal affective disorder, very characteristic type of depression. It's a mild depression that comes only in winter, probably related to the shorter duration of the day. Bereavement, grief, natural. It's a normal reaction and not a disorder. We allow up to 1 year of some kind of depressed mood because of this normal reaction of bereavement, and we're going to differentiate between grief and depression later on in this unit. Postpartum mood disorders, a common thing, commonly seen, the postpartum blues. It's normal to have few days of kind of mood disturbance following the labor of a child, giving birth to a child, but when it is prolonged, when it is associated with suicidal tendency, that's dangerous. That's postpartum mood disorder, and sometimes it can be even postpartum psychosis, and the mother can actually kill her baby because of this serious postpartum disorder. Let's talk about the most common type of mood disorder, major depressive disorder. Major depressive disorder. Again, it's more common in women, average onset around 40. And the pathophysiology behind the major depressive disorder is relative deficiency of 2 important neurotransmitters in the brainstem, serotonin and norepinephrine. This is the major pathophysiologic mechanism of major depressive disorder. And the patients usually present with sadness, sometimes with fatigue, and before starting treatment, you have to rule out an endocrine disease that mimics the presentation of major depressive disorder, that is hypothyroidism. So before starting treatment of depression, you have to check the TSH to exclude hypothyroidism. Also, Parkinson's disease can give similar manifestations. Some medication effects, steroids, beta blockers, can result in some depressed mood, and substance disorder like alcohol, you have to exclude all these, most importantly hypothyroidism. Now, what are the manifestations of major depressive disorder? Remember this mnemonic, SIG-E-CAPS, 8 manifestations. You have to have at least 5 for at least 2 weeks. Remember, for depression, you need to have 2 blue weeks. 2 blue weeks to diagnose depression. What are these SIG-E-CAPS symptoms? Disturbance in sleep, and notice you have sleep disturbance. Some patients can be very, very sleepy and they sleep too much, and some patients can be kind of anxious and they sleep too little. All of them, lack of interest, they don't care, lack of interest, nothing matter. Whatever they used to care about, now they don't care. And huge feeling of guilt, and lack of energy, total lack of energy. These patients cannot get out of bed, they don't have any energy, and lack of concentration, they cannot focus. The appetite is going to change. Some of them can eat too much, some of them will not eat ever. Psychomotor variability. Some of them can be very agitated and irritable and anxious. Some of them are obtunded and kind of not moving. Suicidal tendency, a very important symptom or a manifestation of major depressive disorder. And whenever it is positive suicidal ideation, like something serious, like the patient planned for it, the patient has the tools to commit suicide, this is an indication, an important indication for hospitalization. You have to admit the patient to the hospital if there is positive suicidal ideation. The first line of therapy for major depressive disorder is SSRIs. What are the SSRIs? Selective serotonin reuptake inhibitors. These drugs will increase the concentration of serotonin in the brainstem, and they will improve the depressed mood. Sertraline, Zoloft, citalopram, Celexa, these are just some examples of the many SSRIs we have abundant. We start with this therapy because it's kind of safer than the traditional therapy for depression, tricyclic antidepressants and monoamine oxidase inhibitors. Maybe they are more potent, but they have a lot of side effects. That's why we always start with SSRIs. SSRIs, they need around 6 to 8 weeks to start showing manifestations, but the side effects of SSRIs develop much earlier than the beneficial effects. And the most common side effect is sexual dysfunction affecting males and females. Sexual dysfunction presenting with all kinds of presentations of sexual dysfunction. But of course, males are usually more annoyed about this because of the erectile dysfunction, and whenever a male patient is not tolerating the SSRI because of this erectile dysfunction side effect, the go-to drug is bupropion or Wellbutrin. You can shift to bupropion, and this is an antidepressant with no sexual dysfunction side effects. If the patient with depression is also agitated and irritable, you can give them benzodiazepines at the start of treatment, and always arrange and encourage individual psychotherapy, which always helps in major depressive disorder. ACT, when do we use it for major depressive disorder? Well, we use it rarely nowadays. It's kind of the last resort in severe cases with suicidal risk. Major complication of ACT is transient memory loss. But don't forget, ECT is safe in pregnancy. Why? There is no drugs here. You apply just electroconvulsive therapy. So, how are we going to manage depression? Traditionally, tricyclic antidepressants and monoamine oxidase inhibitors, both of them, they increase the concentrations of norepinephrine and serotonin in the brain. These are the traditional treatment of depression, but they have a lot of side effects. That's why selective serotonin reuptake inhibitors are now the first choice for treating depression, and we start with these SSRIs. So these three major groups, SSRIs, tricyclic antidepressants, monoamine oxidase inhibitors, are like the traditional classic antidepressants. And now we have other antidepressants. The heterocyclics, like for example SNRIs. What are the SNRIs? They are serotonin norepinephrine reuptake inhibitors like venlafaxine, duloxetine, Cymbalta. They increase the concentrations of serotonin and norepinephrine also in the brain. 5-HT antagonists, and we have a lot of other antidepressants like the bupropion thing. The most commonly used yet is SSRIs. Is it grief or depression? Both of them will give sadness, tearfulness, decreased sleep, decreased appetite, decreased interest in the world. The same manifestations, grief and depression. But the symptoms in grief, they wax and wane. But the symptoms in depression, pervasive, unremitting. In grief, shame and guilt, maybe there, but it's very mild and also less common, while shame and guilt is a major thing in depression. And the most important thing, suicidal ideation, very little contribution to grief. is much less common than depression. In depression, suicidal ideation is definitely more common. In grief, the symptoms can last up to 1 year, but they are not going to impair your daily activities for more than 2 months. But in depression, symptoms will continue as long as you want, as long as you're not treating the patient, and usually you don't, these symptoms will interfere with your daily activities. The treatment in grief just supportive therapy, whereas depression needs antidepressants. Our case study of major depressive disorder is about a 75-year-old man who presents to the clinic saying, "I've been down in the dumps for years and it isn't getting any better. I've lost everyone who has ever meant anything to me. I've disappointed my son to the point that he will never forgive me. I don't believe that life is worth living anymore." All are depressed statements. What are the major risk factors that have possibly contributed to depression in this patient? This patient lost his first wife for 27 years. That's a major thing. Unhappy second marriage, social isolation and lack of social support. All these are risk factors. I'm not saying causes, I'm saying risk factors. Does this patient satisfy all of the diagnostic criteria for major depressive disorder? Yes. The patient has at least 5 of the SIG-ECAPS, manifestations. And the symptoms are causing clinically significant distress. And the symptoms are not due to the effects of substance abuse or general medical condition. And the symptoms are not better accounted for simply by grief due to significant loss in one's life. Should hospitalization be considered for this patient? Because the patient has been having suicidal thoughts and has reported that there is a firearm in the home, this is positive ideation. Hospitalization is a must for this patient. Identify the clinical manifestations of major depressive disorder in this patient. Despair. I don't know how much longer I can go like this. Long history of sadness, social isolation and loneliness, guilt, hopelessness, and lack of interest and pleasure. Nothing is fun. And suicidal thoughts and deteriorating memory, forgetfulness, inability to make simple decisions, frequent awakening during the night and early rising in the morning, anxiety, tiredness throughout the day much of the time, and finally often feels stiff and tense in neck and shoulders. These are clinical manifestations of major depressive disorder. Is bipolar disorder here a reasonable alternative diagnosis in this patient? And the answer is no. Why? Bipolar, you should be able to identify some manic episodes. There is no manic episodes here. Now, let's talk about bipolar disorders. Bipolar disorders is a big group in the mood disorders conditions. Bipolar, as the name implies, you have the patient's mood swinging between 2 extremes. Depression, with the classic manifestations of depression, and this is all, the depressed part of the bipolar disorder takes the longer portion of the cycle, but the patient will swing into episodes of mania or hypomania, elated, happy, doing crazy things. And the patient's mood, even if the patient has one attack, one episode of mania or hypomania, this is sufficient to diagnose bipolar disorder. So in bipolar disorders, you have depression swinging, alternating with episodes of mania or hypomania. So to diagnose mania, you need to have 3 of these big fast manifestations for at least 1 week. Remember, 1 fun week to diagnose mania. 1 fun week. Whereas for depression, if you remember, we talked about 2 blue weeks. 2 blue weeks to diagnose depression, 1 fun week to diagnose mania. What are these deep, fast manifestations of mania? Distractibility. Patients with mania are very easily distractible and they have hypervigilance and they don't sleep. Insomnia. They can be up for 3-4 days, and even when they go to sleep, just 1 hour, couple of hours, and they will wake up. They have a lot of energy. and they have grandeur delusions. They think that they are the most important person in the world. They dominate the world, and they have flight of ideas. They can talk in 20 different subjects in 5 minutes, and they have always increased activities, but they are not productive. And increased sexuality and talkativeness. They don't, if you talk to them, they don't give you any chance to respond. They are just talking, and flying from one topic to another. Dig fast. You need at least 3 of these manifestations for one fun week. Now, mania versus hypomania. What's the differences? Well, both of them will give the same symptoms. Both of them will give the same dig fast symptoms. But hypomania is not gonna cause disturbance, major disturbance in life. You're not gonna get arrested because of some manifestations of hypomania. But whenever the manifestations take you or put you in trouble, this is mania. Bipolar 1 is manic episodes alternating with depression. Bipolar 2 is hypomanic episode, at least one, alternating with depression. Rapid cycling bipolar. Whenever you have more than 4 episodes of mania per year, we call this condition rapid cycling bipolar. Mania can get you into severe troubles. So we don't want to have rapid cycling bipolar. Notice, if you have a patient with bipolar disorder, and this patient presented to you in his depressed phase, and you failed to search in the patient's history for a manic episode, and you started prescribing for this treatment, for this patient, anti-depression treatment only, and you gave this patient something like SSRI or tricyclic antidepressant, only something for his depression, what's going to happen to this patient? You are going to precipitate in this patient rapid cycling bipolar, and this patient will develop more episodes of mania. So don't start treatment by antidepressants. If there is even one episode of mania in the patient's history, you should treat these patients with mood stabilizers, because these patients are swinging between depressed mood and manic mood. So you have to stabilize their mood first, and then maybe you can supplement these mood stabilizers by antidepressants. Differential diagnosis of mania: hyperthyroidism and drug intoxication like cocaine or amphetamines. Management of acute mania: hospitalization, mood stabilizers, lithium is the drug of choice. Antipsychotics to control the acute agitation and all these activities, and the drug of choice is risperidone. IM dipophenothiazine. We give them depot intramuscular medication because most of them are non-compliant. Antidepressants only with mood stabilizers. Only after mood stabilizers have been initiated. So the management of bipolar disorder: first line therapy, monotherapy with lithium, lamotrigine, risperidone are alternatives. Second line therapy, any of the aripiprazole, divalproax. Patients with multiple recurrences require combination therapy. Carbamazepine used to be used when lithium and divalproax are ineffective, but is not commonly used now. Plan for psychotherapy and cognitive behavioral therapy. So manic episodes, you need to give mood stabilizers, whether in the manic disorder or the depressed disorders. Lithium, a very good drug for bipolar disorder, but also a very dangerous drug when it comes to the side effects. Side effects of lithium: dose-related tremors, GI distress, headache, nephrotoxicity, and you should encourage hydration. If the patient taking lithium is dehydrated, he will develop renal failure. Nephrogenic diabetes insipidus, hypothyroidism, and teratogenicity. These are the side effects of lithium. A 32-year-old known bipolar patient who is undergoing maintenance therapy with lithium presents with a positive pregnancy test. How will you manage this patient's bipolar disorder? First thing, discontinue lithium, because lithium is going to result in heart abnormalities. And then, are you going to give drugs? No, not in the first trimester. In the first trimester, we're going to do ECT, electroconvulsive therapy, safe during pregnancy. In the second and third trimesters, I can continue with lamotrigine. So this is the plan to manage bipolar disorder patients when they become pregnant. Our case study about bipolar disorder is a 31-year-old female who was brought to the hospital by ambulance following an attempt of suicide. The past medical history, episodes of depression first occurred when the patient was a junior in high school. The patient was diagnosed with bipolar disorder about 6 years ago per the patient's sister. Now, identify these patients' most significant risk factors for bipolar disorder. There is significant family history for mental illness, including bipolar disorder, stressful childhood, and adolescence. List the clinical manifestations of bipolar disorder in this patient. Now, episode of full-blown depression after third pregnancy, development of manic episode 3 weeks after beginning antidepressant therapy in the absence of mood-stabilizing medication like lithium, delusions, part of mania, racing thoughts and racing sometimes incomprehensible speech, staying up all night and pacing about the house, making telephone calls at 3 a.m., sarcasm and hostility shifted from one topic to another, impulsive shopping sprees, and denied that anything was wrong with her, consistent with mania. Now let's talk about psychotic disorders, schizophrenia, and some other, but the most famous is schizophrenia. Psychotic disorders. This is a thought disorders. And patients with psychotic disorders can present with positive symptoms and negative symptoms. Notice, when I say positive symptoms, I don't mean something good. Positive means what? You're doing something that you shouldn't be doing. Negative means you don't do something that you should normally be doing. Positive symptoms are usually associated with dopamine receptors, and negative symptoms are usually associated with muscarinic mechanism. Positive symptoms like what? Delusions, false fixed beliefs, usually bizarre delusions, disorganized speech, behavior, hallucinations, a very famous positive symptom, usually auditory hallucinations. Whereas negative symptoms, flattened affect, social withdrawal, anhedonia, I don't care, apathy, poverty of thoughts. These are the negative symptoms versus the positive symptoms. Schizophrenia, to diagnose schizophrenia, you need to have these negative symptoms plus at least one positive symptom with significant impact on the social or occupational functioning for more than 6 months. If the symptoms are present for less than 6 months, this is called schizophreniform disorder. More than 1 month, but less than 6. Atypical antipsychotics are most effective treatment for the negative symptoms, which are kind of harder to control. Differential diagnosis of schizophrenia. You have to rule out medical illness and other forms of psychosis that are not schizophrenia. So check the TSH for thyroid dysfunction. Check basic electrolyte and calcium to rule out metabolic disorders. Test serology to rule out HIV. Test for syphilis because neurosyphilis can give some manifestations that mimic schizophrenia. Drug screen is the best initial test for a patient with psychosis. You have to eliminate intoxication. Temporal lobe epilepsy can present with auditory and olfactory distortions too. Management of psychosis is by the antipsychotics. And we have two big groups of antipsychotics. The typical, classic, old, traditional antipsychotics, which are no longer used. Only haloperidol may be still used intravenously for severe agitated cases just to control the acute manifestations. Why can't we use them for a long time? Unfortunately, the treatment of schizophrenia is kind of non-curable, so you have to give the treatment for very long times. These drugs, the typical antipsychotics, have very serious side effects. We're going to be talking about them, so we don't put the patient on typical antipsychotics for a long time, and that's why we use atypical antipsychotics, which are kind of newer agents like clozapine, olanzapine, quetiapine, risperidone, and ziprasidone. These are the atypical antipsychotics. So when and what to use, we are going to use, if the patient is acutely agitated, we can use this haloperidol, which is a typical antipsychotic just for short time. Aripiprazole, by the way, is an atypical antipsychotic that is helpful in major depressive disorder also. So the major differences between typical and atypical antipsychotics: typical antipsychotics classically affect the dopamine 2 receptors. They are dopamine 2 antagonists, whereas the atypical, they affect D2, D4 antagonists as well as serotonin antagonists. Haloperidol is the classic example of typical antipsychotics, whereas clozapine, olanzapine, quetiapine, risperidone, aripiprazole, all these are examples of atypical antipsychotics which are used for long term. Side effects of antipsychotics: a lot and serious due to effect on other neurotransmitters, whereas the major side effect of atypical antipsychotics, they will cause hyperglycemia, hyperlipidemia, some sort of a metabolic syndrome, but still these are the ones used for schizophrenia. So the typical antipsychotics, okay, if it is just for an acute, brief timing, like haloperidol just for the acute agitation, but the atypical antipsychotics for long-term management. But notice, clozapine, it's a very potent drug, but don't use it because it can cause agranulocytosis, very dangerous. Ziprasidone can prolong the QT interval. Aripiprazole is a good drug not only for psychosis, but it can help with depression as well. Don't forget the adverse effects of antipsychotics: weight gain, dyslipidemia, hyperglycemia. Whereas the typical antipsychotics, these are the bad side effects: extrapyramidal manifestations, involuntary movements like acute dystonia, tardive dyskinesia, extrapyramidal manifestations, increased prolactin, hyperprolactinemia leading to galactorrhea and gynecomastia and amenorrhea. Secondary to antihistaminic effects, you get sedation, you get alpha blocking side effects, orthostatic hypotension, you get anticholinergic side effects, and this is a very serious side effect, neuroleptic malignant syndrome, where the body temperature increases very much with developing acidosis, and it is a very serious condition. Our case study is about 37-year-old woman who was brought to the state psychiatric hospital by the police after there was an attack on a police officer under City Bridge. The patient is apparently homeless and has been delusional, and she believes that she has been repeatedly raped by alien men on the street. Her speech is rambling, she is oddly dressed, and her hair is greasy and unwashed. The patient claims to be the Assistant Secretary of State for the United States. Identify some of the delusions of this patient. Here are some of the delusions. She believes that alien doctors are in the hospital. She believes that she needs to store food for later when the aliens come. Believes that she has been repeatedly raped by alien men, and the city's water supply has been poisoned, and she believes that she was abducted by aliens, and believes that she can protect herself from aliens with the color red, and believes that she can protect herself with certain phrases, repeating certain phrases. All these are some delusions in this patient. What's the single hallucination in this case study? The only hallucination that the patient has acknowledged in the audible is an audible hallucination, hearing voices from overhead electrical wires and transformers. What other clinical manifestations that are consistent with the diagnosis of schizophrenia in this patient other than delusions and hallucinations? Patient is homeless, violent, attacking a police officer. Speech is rambling and incoherent. Patient is oddly dressed, poorly groomed, invented a phrase to ward off aliens, reports difficulty in keeping jobs, looseness of association is present, insight and judgment are impaired, and patient reports no pleasure in life, and the patient has few social contacts. All these are manifestations of schizophrenia in addition to delusions and hallucination. What's the single risk factor that predisposes this patient to schizophrenia? Is positive family history. Note, schizophrenia has a very strong relation to family history. Does this patient manifest only positive symptoms or only negative symptoms or both types? Actually, she has both types. The positive symptoms, disorganized speech, delusions, hallucinations, and the negative, social withdrawal and anhedonia. Now, let's talk about a very, very, very common psychiatric disorders and anxiety disorders. Now, the general principles of anxiety disorders. What's anxiety? It's a state of fear or concern out of proportion to the situation. You have the fight and flight symptoms, hypervigilance, ruminating worry, insomnia, tachycardia, nausea, trembling, sweating, feeling short of breath, agitation, difficulty swallowing, again out of proportion to the situation. You have to rule out MI, myocardial infarction, in any case of acute panic attacks or acute anxiety. Substance abuse also can cause acute anxiety, like cocaine. Hyperthyroidism can result in severe anxiety, hypoglycemia. Don't forget, rule out MI. The pathophysiology is imbalance between the major neurotransmitters in the raphe nuclei. The imbalance with serotonin. Serotonin has a lot to do with this anxiety. But the mainstay of treatment, SSRIs on the long term, SSRIs, selective serotonin reuptake inhibitors. Benzodiazepines we only use for short time to control acute anxiety and psychotherapy. Here is a table that summarizes most of the characteristics of the different anxiety disorders. We have panic disorders, we have specific phobias, we have social phobias, we have generalized anxiety disorder, we have OCD, and we have acute stress disorder or post-traumatic stress disorder. In panic disorder, there is nothing that triggers this anxiety. You just become severely, acutely anxious, and it's panic attack and fear of another panic attack, and this is where you need to rule out myocardial infarction. But sometimes you can have specific item that can trigger this panic and severe anxiety, and these are signs like fear of closed spaces, fear of heights. These are the specific phobias, and we can treat it by exposure and cognitive behavioral therapy. Social phobias, the trigger is possible embarrassment. You have this social phobia because you have a fear to get embarrassed in front of so many people. Generalized anxiety disorder is when you just worry about everything and you have just anxiety about everything that happens in your life. This is the generalized anxiety disorder. OCD is some sort of anxiety due to you are obsessed with some thoughts, like you go to sleep. Did I close the front door really well? And this triggers anxiety in you. What if I did not close it? Then thieves might come and they might attack me. So you start getting anxious. How to get rid of this anxiety? Do you think you can take a Xanax pill and get rid of anxiety? No, you have to do something. You find yourself compelled to get up and go and check that door, and this is the compulsion component of OCD. So in OCD we have obsession, and this obsession brings anxiety, and this anxiety cannot be relieved except by doing something. You find yourself compelled to do something. This is the compulsion, obsessive compulsive disorder. Acute stress disorder, when you have this anxiety following an incident or an event and it lasts for less than 1 month. If it lasts more than 1 month, we call it post-traumatic stress disorder. Drugs used for anxiety. Mainstay treatment, as I said, for long-term, SSRIs, for short-term benzodiazepines. For short-term benzodiazepines. Benzodiazepines, they work on specific benzodiazepine receptors present in many brain regions, including the thalamus, limbic structures, and the cerebral cortex. The benzodiazepine receptors, they form part of a GABA receptor chloride ion channel. And here is a diagram for it. When the benzodiazepines attach to these receptors will kind of open, and this will allow chloride to get inside the neurons. Chloride is a negative ion. Whenever you increase negativity inside the cells, this calms down, this sedates the cell. So benzodiazepines, they work by what? They increase the frequency of GABA-mediated chloride ion channel opening, allowing chloride to get in, and this will sedate the cells. We have so many different benzodiazepines. Some of them are long-acting, like diazepam, chlordiazoxide. Some of them are intermediate-acting, and some of them are very short-acting, like midazolam. Benzodiazepines are metabolized in the liver, except 3 that are metabolized outside the liver. Outside the liver. Oxazepam, outside. Temazepam, lorazepam, liver. So remember, outside the liver, these are the liver-safe benzodiazepines. The short-acting benzodiazepines are useful to manage panic attacks, to manage status epilepticus. The medium acting benzodiazepines with half-life between 12 and 40 hours for anxiety and insomnia. The long-acting benzodiazepines for chronic panic disorders, but we don't like to put our patients for a long time on benzodiazepines for dependence, but they are used also to manage alcohol withdrawal. Our case study is about generalized anxiety disorder. Here we have a 23-year-old woman who complains of worrying all the time about everybody and everything. Also, she complains of waking up at 3 a.m. every morning and not being able to go back to sleep. Why was it appropriate to test for thyroid functions in this patient? Hyperthyroid disease is a relatively common cause of anxiety. However, both tests for thyroid were normal in this patient. Why was it appropriate to test for urinary catecholamines in this patient? Although rare, there is a tumor of adrenal gland known as pheochromocytoma that causes sympathetic nervous system hyperactivity by secreting catecholamines in the bloodstream. But in this patient, urinary catecholamines were normal. Why does this patient have at least 3 of the 6 required clinical manifestations of generalized anxiety disorder? Yes. What are these? The patient complains of difficulty sleeping throughout the night, difficulty concentrating on her studies, and feeling grouchy, irritable lately. Furthermore, she also complains of being tired all the time, fatigue, and has been unable to relax. Why is an EEG appropriate test in this patient? EEG, electroencephalogram, is helpful in determining whether an intracranial lesion, sometimes tumors or abscess, may be causing this patient's anxiety. If an abnormal EEG had been obtained, brain imaging by CT should be done. Attention Deficit Hyperactivity Disorder, ADHD, a common diagnosis especially in kids, especially in children. ADHD is characterized by inattentiveness, hyperactivity, and or impulsivity that results in difficulty functioning in at least 2 settings. 2 settings. You need to have 2 settings where the child is hyperactive, showing the manifestations. Maybe school and home, maybe church and school, maybe home and church. You need to have at least 2 settings. Symptoms must be present for at least 6 months. ADHD is a risk factor for substance abuse in adolescence. So notice, you have to follow up these kids, because a kid with an ADHD is a possible candidate for substance abuse when in his or her adolescent period. Most commonly, it affects more commonly boys than girls. A differential diagnosis of ADHD is age-appropriate behavior. Come on, he's just a 6-year-old boy. What do you expect of him? So ADHD must result in difficulty functioning in at least 2 settings in order to diagnose it. Oppositional defiant disorder. This disorder, the patients are usually more argumentative and hostile. They show hostility towards figures of authority. Mood disorders, sometimes they share the inattentiveness thing with ADHD. Drugs used for ADHD. We can use stimulants or non-stimulants. Now, here's the thing. You might think, how can I use stimulants for a child who is already hyperactive? Now, here's the explanation. These children, when they become hyperactive, this results in increased level of catecholamines in their brain, so they become satisfied. So they are hyperactive in order to achieve this high level of catecholamines in their brains. When you give them stimulants that are mainly amphetamines that increase the catecholamines in their brain, so guess what? Mission accomplished. We don't need to become hyperactive anymore because we already have high concentrations in our brains thanks to these stimulant medications. And this is the rationale for using stimulants in these kids. But one bad thing about stimulants, they turn your child into a robot. So they cause emotional blunting. The child is a very disciplined robot. We do not like our children to be robots. We want them to show these kind of tiny little silly behaviors of their age. Therefore, the management of ADHD now is a combination of stimulants and non-stimulants medications like what? Atomoxetine, Strattera. Strattera is a non-stimulant medication. It works as a selective norepinephrine reuptake inhibitor, and it does not cause this emotional blunting side effect. Examples of stimulants, which are scheduled drugs, the famous Adderall and Ritalin, these are amphetamines. They are scheduled drugs. The examples of non-stimulants, which are non-scheduled drugs, Strattera, atomoxetine, and guanfacine, Intuniv, guanfacine SR. Our case study is a 6-year-old boy who presents to the pediatric clinic with his mother. The mother states that her son has shown hyperactive and inattentive behaviors now for almost 1 year. Teachers complain that the boy does not listen to them, does not follow instructions, is easily bored during activities, and has difficulty both waiting his turn and engaging in playground games for any significant length of time. What is the patient's single most critical risk factor that is consistent with ADHD? It is positive family history for the illness. Does this patient satisfy all of the criteria required to diagnose ADHD? Yes. Now, either 6 of 9 inattention or hyperactivity impulsivity criteria are present for at least 6 months. This is what you need to diagnose. Onset occurs before the age of 7 years. Symptoms are present in 2 or more settings. Behavioral disturbance causes clinically significant distress, and behavior cannot be explained by other psychological disorders.